What's up, Ninja Nerds? In this video, we're going to be talking about seizures and epilepsy, as well as taking a discussion down the road of status epilepticus. Before we get started, it's so important for you guys to continue to support us. And the best way that you guys can do that is by hitting that like button, commenting down in the comment section, and most importantly, subscribe. All right, Ninja Nerds, let's get into it. All right, Ninja Nerds, so what the heck is a seizure? A seizure is basically this abnormal, excessive, synchronous electrical activity that occurs within the central nervous system that can lead to outward manifestations, which we'll talk about in the clinical features like focal and generalized seizures. Now, what are the potential causes, the triggers, the reasons why people develop seizures, and then how does the pathophysiological mechanisms occur that trigger these seizures? The easiest way to remember the causes of seizures is through the mnemonic vitamin, D, and E, and we'll go through each part systematically. The first one is your vascular causes. So these are very common for focal kind of structural causes leading to focal types of seizures usually, but they can cause generalized. This includes acute ischemic strokes, intracerebral hemorrhage, and subarachnoid hemorrhage. Another common cause is whenever you have very, very high blood pressure that causes some vasogenic edema to occur with inside of like the posterior cerebral territories that is visible on MRI. You see the vasogenic edema, they have hypertension, it's visible on the MRI sequences. We call this posterior reversible encephalopathy syndrome. This is basically hypertensive encephalopathy, basically. The next one is whenever you have severely low oxygen levels in the blood, so low that there's almost no oxygen being delivered to the brain, and a very large area of the brain suffers from that severe hypoxia or anoxia and then can develop seizures. This is called anoxic brain injury. So to summate the vascular causes, so that you guys don't forget them, it includes acute ischemic stroke, intracerebral hemorrhage, subarachnoid hemorrhage, hypertensive encephalopathy, but if it presents with vasogenic edema on the MRI, it's called PRES, posterior reversible encephalopathy syndrome, and then severe anoxic brain injuries. Boom, roasted. Let's move on to the next part. The next thing I want you to remember is infectious causes, so VI. Infectious causes include meningitis. That's very close to the cortex. And so that irritation of the meninges can also irritate the nearby cortex. The next one is if you irritate the actual brain tissue itself, and that is called encephalitis. Okay, encephalitis. The next one is when you have a big loculated accumulation of pus and bacteria or other types of microorganisms that are accumulating near the cortex. And this is called a brain abscess. Okay, brain abscess. So, three particular infectious causes that I want you to remember: either inflammation of the meningitis, inflammation of the brain tissue, encephalitis, or a big loculated accumulation of infectious material called an abscess. These things need to be near the cortex, though, in order to trigger seizures. The next one, so we got the first part of our vitamin D and E mnemonic. The next one is traumatic causes. So traumatic causes that I want you to think about here is if you form kind of a lens-shaped bleed, that is called an epidural hematoma. Or if you form this crescent-shaped bleed. So epidurals are usually a rupture of the middle meningeal artery. Subdurals are usually venous bleeds. And so this is called a subdural hematoma. These are near the cortex, can agitate the cortex and trigger seizures. The next one I want you to remember is autoimmune causes. So there's some type of antibody-mediated activity on the actual brain tissue causing some type of autoimmune type of encephalitis to be present. And so one of the big triggers to remember is there is a very common autoimmune disease that can trigger antibodies to attack the brain tissue, and this is called systemic lupus erythematosus. So please remember that one. The other thing to remember is that sometimes people can develop what's called paraneoplastic syndromes. You're like, what in the heck does that mean? So paraneoplastic syndromes is you have some type of neoplasia, and then what happens is that cancer leads to the production of antibodies that'll go and attack other tissues, in this case, the brain tissue. And so this also can cause an encephalitis. So again, big thing to remember for autoimmune causes is it can either be due to an autoimmune disease like systemic lupus erythematosus, or paraneoplastic syndrome where somebody has like a small cell lung cancer and they develop antibodies that attack the brain tissue, particular receptors of the brain tissue. Either way, they're attacking the cortex and leading to an autoimmune type of encephalitis. So usually this may present as an autoimmune encephalitis that can lead to seizures. Okay? So we have these parts of the vitamin D and E mnemonic. Let's move on to the other parts. All right, so we talked about the first part of our vitamin D and E mnemonic. The next part here begins with M, metabolic causes. Now, metabolic causes usually cause more like diffuse types of seizures. And the particular ways that I like to remember these is, let's think about some of the nutrients and electrolytes that are inside of the blood and even vitamins. One of the big ones is vitamin B1, thiamine. Thiamine is a very important vitamin, and it's very important with a lot of electrical activity. So sometimes whenever there is a thiamine deficiency, a decrease in vitamin B1, that can occur in things like Wernicke's encephalopathy and alcoholism, that could be a potential cause for a seizure. The other thing is glucose. Whenever you lower those glucose levels, hypoglycemia is a very intense trigger for someone developing a seizure. Weirdly enough though, in some situations, it's also important, not as common, but sometimes even high glucose levels. Less common, let's actually put here an abbreviation, less common, high glucose levels can also cause seizures. The next one is sodium. Sodium regulates a lot of that movement of water to and from the actual cerebral tissue and blood. And so whenever there is low sodium, so hyponatremia, or high sodium, but more particularly low sodium is a little bit more common of a trigger. So hypo or hypernatremia can also be triggers for seizures. Calcium, whenever you have low calcium, that is really going to cause a lot of seizures to occur. Another one, magnesium. Magnesium really stabilizes a lot of membranes and regulates the activity of calcium channels. So low magnesium can also trigger seizures. And last but not least, low phosphate level, hypophosphatemia can also trigger seizures. So what, again, metabolic nutrient kind of molecules that are important to remember? A deficiency in thiamine, low glucose, hypoglycemia, less common, hyperglycemia. Hyponatremia, more common. Hypernatremia, a little bit less. And then hypocalcemia, hypomagnesemia, hypophosphatemia. These are the potential triggers with this aspect of the metabolic causes. The next thing, think about the kidney. The kidney, if someone accumulates a lot of urea, so if there's an increased accumulation of urea, this also can cause some type of trigger of seizures. So increasing urea, increasing kind of metabolic waste. Let's put increased in waste, metabolic waste, okay? The other one is the liver. So think about that good old beautiful liver. If the liver decides, hey, I'm gonna start making, I'm gonna have less ammonia, that's actually being converted into urea. And so now, because of my liver failing and I'm not able to take and perform the urea cycle as appropriately, I'm going to build up a lot of ammonia. And that ammonia also has the ability to trigger seizures. Next one is the thyroid gland. And someone who has, think about it, hyperthyroid, everything's sped up, that could be causing seizures as well. So when someone has an elevation in their T3, T4 levels, that can also trigger seizures. So to quickly recap metabolic causes, thiamine deficiency, hypoglycemia, less common hypernatremia, hypocalcemia, magnesemia, hypophosphatemia, uremia, liver failure, and hyperthyroidism. Let's move on to the next one. Idiopathic causes. Now, idiopathic causes is actually what we term epilepsy. Okay, we really could define this more as epilepsy. So epilepsy is a little bit different from seizures in a way that epilepsy is where you have two unprovoked seizures greater than 24 hours apart is how we kind of define epilepsy. Another newer definition in 2014 was that you have an unprovoked seizure with at least a 60% reoccurrence rate. So either way, it's whenever someone has multiple seizures is that they're more likely to have epilepsy. And these could be due to a couple things. And we'll talk about these. One is if that person has epilepsy, okay, and they're being treated with anti-epileptic medications, what if they are either on that anti-epileptic and they're either not taking it because of side effects or they just don't want to, or the level of the AED is subtherapeutic. They're not in a nice therapeutic range and their dose wasn't increased appropriately for whatever reason. That's a potential trigger. The other one is epilepsy syndromes, and there are so many different types of these, and this is more pertaining to like pediatrics. But this can include things like West syndrome, which usually presents with like these infantile spasms. This can present with a very sad case called Lennox-Gastaut syndrome. And then another one is called a juvenile myoclonic epilepsy. And again, this is just some of many different types of epilepsy syndromes, okay? So idiopathic causes, when we really say idiopathic, we're talking about people with epilepsy who either have an epileptic syndrome of some kind, or they're just either not compliant with their AED or it's not at the therapeutic dose. So think about that as another potential cause. So far we're up to I of vitamin D and E. What's the next one? Neoplasia. So this is another structural type of cause that usually can present more with focal seizures. But if you have a neoplasia that's again near the cortex, it has to be near the cortex to really trigger seizures, or it has to be something really diffuse like metabolic in nature. If that's the case, then when these are having these neoplastic things, like someone has, for example, a big old nasty mass, one of the scariest ones that you can develop within the brain is like a glioblastoma multiforme, right? That could be a potential one. Or you have a mass that develops within the meninges compressing onto the cortex of the brain. What could that be due to? That could be due to a meningioma. And sometimes there even could be you have a mass somewhere that spread to the actual brain from another primary location and it metastasized. So this could also be some type of malignancy that's secondary to metastatic type of activity there, okay? So that's the next thing to be thinking about. All right, the next cause within our vitamin D and E mnemonic is drug causes. Now, drug causes, similar to like metabolic causes, as we mentioned above, these things lower your seizure threshold. So they just kind of lower the threshold at which a seizure could be triggered. There's a bunch of different medications. I don't want you to remember every single medication, but some of the important ones to remember can be remembered by this mnemonic Otis Campbell. And so the first one is opioids, and this includes drugs like meperidine and tramadol. They seem to be very strong triggers. Tricyclic antidepressants like amitriptyline, nortriptyline, even anticholinergic drugs. Isoniazid, which is used to treat tuberculosis, remember that in a clinical vignette, as well as salicylate toxicity, so taking maybe too much aspirin. Another one is a double whammy, cocaine for C, as well as cefepime, which is a type of cephalosporin antibiotic. A for amphetamines, which includes things like Ritalin and Adderall. M for metronidazole, which is a type of antibiotic. P for penicillins, which are types of antibiotics. B for benzo withdrawal, as well as, don't forget, the medication bupropion, which is Wellbutrin, okay? Another one is ethanol withdrawal, and last but not least, lithium. These are all common drugs that you guys need to remember that it could be potential causes of someone developing a seizure by lowering that seizure threshold. If you want to be really, really extra smart ninja nerds, you guys can add into the D of drug causes 2 other types. I'm not too concerned if you don't really want to remember them, but they can be added on into the drug, like the D part of the mnemonic, and this includes degenerative diseases, things like Alzheimer's, And the other one that you could add into this is demyelinating diseases, including multiple sclerosis, okay? So if you guys want to be extra ninja nerds, you can add these into that D part of the vitamin D and E mnemonic. The last part of our mnemonic here is E for eclampsia and kind of everything else that you can kind of think of. Eclampsia is a very strong trigger of this. So eclampsia would be, again, when someone's pregnant, they're pregnant, they also have high blood pressure. So pregnant, we'll put prego, high blood pressure, and they also have seizures. It's kind of the classic things with eclampsia. So that could be one thing. Everything else, just mentioning a couple extra things to remember here, is fevers. Fevers can be a pretty strong trigger, especially in children. So whenever they have a very particular viral infection called roseola, which is a human herpes virus infection, that can cause febrile seizures as well as a rash. And then the last one, we are not going to go through all of these, but there is particular genetic causes that predispose someone to seizures. Things like phenylketonuria, things like a lot of mitochondrial diseases and lysosomal disorders and peroxisomal disorders, so many different types. But these are the big causes that I want you guys to remember as potential triggers of seizures. Now that we know the causes, based upon our vitamin D and E mnemonic, the next thing I want us to talk about is how these things really lead to pathophysiologically, neurologically, at the cellular level, seizures. All right, so we have our causes. Now, how do these particular causes at the cellular level generate seizures? Let's have a big kind of like general overlaid understanding of it. The basic pathophysiological mechanism is that there is a decrease in the inhibitory pathway, which is primarily the GABA pathway, and there is an increase in the stimulatory pathway, which is primarily the glutamate pathway. Let's start with glutamate. Now, for whatever reason, in these individuals who develop seizures, there is an increase in glutamate production, or an increase in the glutamate activity on the particular receptors that are on this postsynaptic neuron. And there's two different types of receptors to remember. One is called the NMDA, and the other one is called the AMPA receptors. Either way, whenever glutamate binds onto these little channels, it allows for cations like calcium and cations like sodium to enter, and even magnesium, to enter into the cell. Whenever cations enter into a neuron, what do they do to the inside of the cell? They make the inside of the cell super positive. When you make the inside of the cell super positive, that creates just enough positive charge to activate voltage-gated channels that are present on this axon and lead to a propagation of depolarization down this axon. What is that called? An action potential. So this could lead to a depolarization, and then therefore action potentials. If you have increased glutamate because of this whole theory of increased positive activity pathway, there'll be more glutamate, more activity on the AMPA or NMDA, more calcium, more magnesium, more sodium influx, more positive charges, more depolarization, more action potentials, and that's where you get that abnormal, excessive, synchronous electrical activity that can occur within the central nervous system. The other pathway is very interesting. So the basis of this pathway is that there is a problem with these channels here. These channels here are called your GABA A receptors. And what's believed to be wrong in these patients is by any of these causes that we discussed, these are dysfunctional and they don't respond as well to GABA. So for example, if GABA is released, when GABA acts on this type of channel, normally what would you want to happen? Normally what would happen is these channels would open, and this would allow for ions like chloride to enter into the cell. If chloride were to enter into the cell, what does chloride, its kind of charge is? It's negatively charged. That negative charge would be enough to inhibit the activity of action potentials down what? Down the axon. And if you decrease the actual voltage inside the cell and decrease the action potentials, this can lead to hyperpolarization. Okay, so what is this called again? This activity where you make the inside of the cell extra negative because of bringing chloride ions is called hyperpolarization. Then if you have hyperpolarization, you make the inside of the cell negative, it's unlikely that action potentials will be triggered. So you'll have decreased action potentials, right? Now, think about this. If there's a decrease in the GABA pathway or that inhibitory pathway, even though GABA may be present at normal levels, there's decreased reaction of these GABA receptors to GABA. That means decreased chloride ions are coming into the cell. That means decreased negative ions are accumulating into the cell. That means that there is decreased hyperpolarization of the cell. If there's decreased hyperpolarization, that means the cell is not becoming as negative. It's not as inhibitory. And instead, it'll cause an increase in action potentials. So you lead to an increase in action potential, which leads to an abnormal, excessive electrical activity that is synchronous with inside of the central nervous system, whether it be due to a decrease in the inhibitory pathway due to GABA receptor dysfunction, or an increase in the glutamate pathway via the increase in glutamate or increased sensitivity of those receptors to glutamate. That is the method or the pathophysiology. Now, here's where it gets even cooler. If these abnormal electrical activities occur within the brain, our central nervous system, if you will, how can it actually present? And that's the good question to think about. So whenever this abnormal electrical excessive synchronous activity is occurring by the causes and the mechanisms that we discussed, let's say that there's a particular focus where this electrical activity is occurring right here. And now that is going to spread, that abnormal electrical activity is going to spread to other parts of the brain, but it's going to stay in this one cerebral hemisphere. That is called a focal seizure. So a focal seizure is occurring at one point, usually involving kind of one hemisphere of the actual cerebral cortex. But let's say that you have a focus, some focus here, and what happens is this electrical activity is occurring throughout all parts of the cerebrum and the bilateral cerebral hemispheres. Holy crap, what is that called? That is a generalized seizure. So big thing to remember here, focal seizure usually is it's occurring in one point, stays within that one hemisphere due to this mechanism we talked about above, or that abnormal electrical excessive synchronous activity is occurring in bilateral cerebral hemispheres, which is a generalized seizure. This leads us into our next discussion, which is clinical features. All right, Ninja Nerds, so now let's talk about the clinical features with seizures. We already kind of introduced that there can be focal seizures and generalized seizures. So we have here focal seizures. We're going to talk about them, and then down here we'll talk about generalized seizures. So first thing with focal seizure, just to quickly recap, there is a focal location where this abnormal electrical activity is occurring and spreading throughout that one cerebral hemisphere, right? And staying within that cerebral hemisphere. When that happens, you want to think about this. Whenever there's abnormal excessive electrical activity within a particular part of the brain, think about your anatomy and physiology of the brain. So first thing, frontal lobe. What are the big things to think about that are controlled within the frontal lobe? There's a lot of motor activity that occurs within the frontal lobe. Your primary motor cortex, your supplementary motor cortex, your frontal eye fields, Broca's area, a bunch of different things. So whenever you have, for example, let's say that the right frontal lobe, there's a lot of this abnormal excessive electrical activity, you may start developing movements, abnormal movements on the contralateral side. And we'll talk about that, the different ways that those movements can present. The other thing is think about sensory symptoms. So think about the other lobes. So think about, for example, this blue one here, that's right behind the central sulcus. So think about parietal. That's where a lot of your sensations, somatic sensations occur. Think about here in purple, think about the occipital. That's where a lot of the visual sensations occur. And then think here in green, think temporal. And you can even include in the insula a little bit. And that's where a lot of auditory sensations as well as other kind of primitive sensations also occur. So for example, what I want you to remember here is, again, sensory symptoms. So for example, as an example, we'll give you more examples. If you have a seizure that is going on within the right parietal lobe, you may have abnormal sensations of the arm and the leg on the contralateral side, maybe pain, paresthesia, so on and so forth. Okay. The last one I want you to think about here is, again, kind of tucked deep within this, again, temporal lobe. And then even add on to this the insula. These can lead to very interesting types of symptoms whenever you involve the temporal lobe, the deep temporal lobes, the insula, limbic structures there. It can lead to autonomic symptoms as well as psychological symptoms, and we will discuss what the heck I mean with that as well, okay? So whenever someone talks about, again, focal seizures, it's abnormal electrical activity that is excessive, it's synchronous within one area, staying within that cerebral hemisphere. If it affects particular parts of the brain, it can lead to what kind of main symptoms? Abnormal motor symptoms, abnormal sensory symptoms, abnormal autonomic symptoms, and abnormal psychological symptoms. And that is particularly with focal seizures. Before we start talking about the basics of generalized seizures, I want us to talk about the anatomy, the basic kind of process of seizures, since we're getting ready to introduce this. Whenever someone is having a seizure, there's a stage or phase kind of process that they go through. So what is that? So let's say that we first start off with the trigger. We already talked about them, all the different vitamin D and E causes. So we can talk about there is a trigger, right? And that trigger could be any of the vitamin E and D causes. It also can include other simple ones that could be superimposed on those. What's very common things that most people know? Stress, severe stress, sleep deprivation, very bright lights and bright sounds on top of, superimposed on any of these issues we just discussed, can trigger a seizure activity. Now, once you have that trigger, this can lead to, in some patients, if it's a focal seizure, it can lead to something called an aura. What the heck is an aura? An aura consists of a couple different things. So let's describe what an aura is. An aura is you usually feel a couple different things. One is deja vu. Okay, this kind of impending sense of fear, this impending sense of doom in some way, shape, or form. You may have some nausea, this kind of feeling of like nausea that kind of moves throughout the abdomen up into like the chest. You may exhibit what's called automatisms. What the heck is automatisms? Automatisms is when someone's like doing this. Rapid blinking of the eyes. So maybe if they're doing rapid blinking, if they're chewing and lip smacking, that could also be kind of an automatism. So chewing, like abnormal chewing, even though they don't have any food or gum in their mouth. So they're just kind of like an abnormal chewing, or they're smacking their lips. These are common kind of automatisms that you can see with these patients. So if someone comes, they have a trigger, bright lights, bright sounds, stress, sleep deprivation, superimposed on all the vitamin D and E causes, boom, they feel this impending sense of doom. They feel this nausea. They start rapidly eye blinking. They start having these lip smacking and chewing type of symptoms. Then what can happen? This is kind of a premonition letting them know, hey, seizure coming, baby. And then what will happen? They will start to seize. And so we call this the ictal event. And that's where we're really going to discuss a lot of the different characteristics of if it's a focal or generalized seizure. And that's where you kind of see, this is where sometimes if someone's coming into the emergency department or you see in a movie, someone's thrashing around, that's their ictal event. But maybe previously they may have had some type of aura or a trigger that we're just unaware of. After the ictal event, they have what's called a post-ictal phase. And the post-ictal phase is very important. The post-ictal phase, after the person seizes, whether it's a visible seizure like a focal seizure, or whether it's a non-convulsive seizure, or whether it's a generalized seizure, whatever it may be, after that ictal event occurs, they can show certain types of symptoms that they had a seizure. And usually the post-ictal phase occurs usually in two types of seizures. So focal with impairment, or a full-on generalized seizure. So if you have focal seizures with impairment, a generalized seizure, and then one more, which is a focal that's secondarily generalized. And we'll describe what the heck I mean by that. So it's either you had a focal seizure where you lost consciousness or you were impaired, you had a generalized seizure where you lost consciousness, or you started off with a focal seizure with impairment that became generalized secondarily. In these issues, these types of situations, their post-ictal state, the symptoms that they usually show include, usually they're confused, they're lethargic or really drowsy. They have amnesia. They don't even remember what the heck happened. They could go up and say, hey, do you remember what happened? They're like, no, I just kind of blacked out. And also, here's a common one that they love to ask on the boards, is especially in focal seizures with impairment, they can develop what's called Todd's paralysis. And that's basically where they have weakness on one side of the body, okay? And that's usually common after a focal seizure with impairment. So quick anatomy of a seizure. You have a trigger, lead to potentially, if it's a focal seizure, especially with impairment, you can develop an aura. Aura, deja vu, impending sense of fear, nausea, automatisms, leading to an ictal event. The actual visible scene of a seizure. Focal seizures, generalized seizures, or focal that becomes generalized, or even, sometimes you might even see it, it could be a non-convulsive seizure. And then after the ictal event occurs, you have a post-ictal phase. And that post-ictal phase is usually only common in seizures that are focal with impairment, focal that secondarily generalizes, or a generalized seizure, and it's classified as having afterwards being confused, lethargic, fatigued, forgetting, having amnesia of what happened, and especially, don't forget for your boards, in focal seizures with impairment, they also have weakness or paralysis on one side of the body that usually goes away over time, called Todd's paralysis. Okay, now that we hit kind of the anatomy and pathway of a seizure, let's start talking about these ictal phases here, focal and generalized seizures in more detail. All right, cool. Focal seizures with the motor type. So again, this is primarily a seizure being generated within the frontal lobe. This can present as in a couple types of ways. The first one that I want you guys to remember here is atonic. So basically, atonic is their muscles just become super lax and weak and they can collapse actually. Another one is the exact opposite of atonic. It's tonic, they're stiffening of the muscles. Clonic is there's quick jerking of the muscles. Myoclonic is there is a asynchronous, very rapid jerking movement. And then last but not least is you can have these movements that we just talked about in a very, very weird way that is very common in situations where a patient, especially you need to remember this for your exams, called a Jacksonian march. What the heck is a Jacksonian march? Let's say that you have a clonic seizure. It starts in the hand, then it moves up into the forearm, Then it moves up into your upper arm, and then your entire arm is involved. A Jacksonian march is it usually starts at a distal limb and works its way proximally. This is common in motor seizures in one of these types of forms, usually clonic. Okay? So that's a big thing to remember. So we'll write distal to proximal kind of spread. Okay, so don't forget that Jacksonian march, distal to proximal spread of these types of motor movements. All right, that describes that. Now, one quick thing here is that if people present with these kind of focal motor seizures, there's a couple classic ways that they can show up. We talked about the different types of contractions that they'll exhibit, but how will it visibly look, I think, is an important thing. And so some of the ways that that may present is they may have, like we already kind of showed you, a unilateral shaking of a limb. Another thing that could be not as obvious is their eyes could be hardly deviated to one side. So maybe you look, and if they have a seizure going on in like the left frontal lobe, they may actually have their eyes deviated to the contralateral side. So that's important. And then the last thing is they may have their head cocked or turned to one side. So head turning to one side, hard eye deviation, as well as unilateral shaking can be signs of focal motor seizures. Now, focal sensory, it's really straightforward. I want to go through the cortex, and we'll kind of try to color code these things accordingly. So first one, blue, somatosensory cortex. If you're having abnormal electrical activity, you can feel abnormal sensations, so feeling pain and or paresthesias. So kind of a pins and needles feeling. And you know what's interesting about this? This can also occur in a Jacksonian march type of fashion. So where you feel abnormal pain and tingling and numbness in the hands that then spreads up to the forearm, that then spreads up into the upper part of the arm, that then spreads up into the shoulder. So you can still have Jacksonian marches with focal sensory and focal motor. Anyway, the next one we picked, purple. So if there is kind of abnormal electrical activity within the occipital lobe, this may lead to visual hallucinations. So you maybe see things that aren't actually present. So visual hallucinations. Okay? The other one, now move on to the green. There's a couple different things within the green, that temporal lobe. So first one is primary auditory cortex. So you hear abnormal sounds. Maybe you hear kind of an abnormal ringing in the ears that actually is not even present. Or the primary olfactory cortex, so you smell things intensely or abnormal that isn't really there. Maybe you smell some type of abnormal smell. Maybe you smell burnt toast for whatever reason. And then inside of the temporal lobe, tucked in there, is also the gustatory cortex, kind of within the insula a little bit. And that is responsible for taste. And so there may be abnormal taste in your mouth, even though you're not actually chewing or eating or drinking anything. Maybe you have this weird like metallic taste in your mouth as well. So to recap, again, focal sensory seizures, they can present, if it's somatosensory, kind of pain and paresthesias. They can present visual hallucinations. If it's auditory, they can hear abnormal sounds like ringing. If it's olfactory, they can smell abnormal, intense smells like burnt toast. Or if it's abnormal, if it's the gustatory cortex, abnormal, weird tastes like maybe a metallic taste in the mouth. Okay? The last part for the focal seizures for the particular lobes that are involved here, especially again temporal lobe, is those autonomic symptoms. So this is really particularly when you get to the insula. The insula can actually regulate a lot of your autonomic activity. And so whenever there's autonomic involvement, that can also lead to some interesting symptoms, which include what? It can really increase your cardiac activity. So it can increase your heart rate, leading to tachycardia, and it can also increase your blood pressure, leading to hypertension. It can also act on the actual bladder system, okay, and it can lead to urinary incontinence. And it can actually affect salivation as well, okay, and sweating. So it can even lead to salivation and sweating, okay? So whenever there's abnormal firing of areas within the temporal lobe, particularly tucked near the insula, it can lead to autonomic symptoms like high blood pressure, tachycardia, urinary incontinence, as well as increased salivation and sweating. Now, if you start getting into that temporal lobe as well, temporal lobe, a lot of the structures within there are the limbic system, right, which control a lot of our emotions, our behaviors. And so one of the big things to think about is emotions, right? So sometimes people can exhibit like emotional behavior, okay? And so maybe they can present like really angry, or maybe not only can they present really angry, maybe they present like hypersexual. So sometimes hypersexual behavior is another thing to think about as well. And the last thing to think about here within this list is particularly some other kinds of psychological symptoms, such as, we already talked about this one, déjà vu, where you kind of have this sense of impending kind of doom or fear, depersonalization, where you have kind of this disassociation from kind of yourself or the environment, or derealization. Okay, which is again kind of a disconnect from your environment as well. So these are particular symptoms that you can exhibit. So again, we talked about focal motor, focal sensory, focal autonomic, and psychological symptoms that you can see with focal seizures. A couple more things that we have to talk about before we go into generalized seizures is if these focal seizures that we can see presenting in any of these ways are causing impairment, potentially loss of consciousness, or no impairment, there's no loss of consciousness. And so in those situations, it's important to understand some of the things that can maybe clue you into that. And what are those things? Here, first, before we talk about that, it's important to remember your anatomy. So when we say with impairment, it may be meaning that these seizures are involving some particular areas of the brain and brainstem. So let's say that here you're having your focus of seizure activity. And that focus of seizure activity that's causing with impairment is involving some particular structures here. Maybe it's involving the reticular formation, which you know is the seat of consciousness. Well, particularly helps with not the seat of consciousness, but more particularly with our arousal, what we decide. It sifts through all sensory information and decides what we need to be alerted about or aroused about. So it's kind of our arousal system, if you will. And the other structure here is the thalamus, which is kind of the relay station for all sensory information going into the central nervous system. So whenever focal seizures involve the thalamus and they involve the reticular formation, it can lead to impairment, loss of consciousness in a way. And so because of that, there may be a loss of consciousness. That's one thing that can help with focal seizures. The second thing is that usually focal seizures with impairment also present with auras, right? So they present with automatisms, nausea, déjà vu, some of those kinds of things. And on top of that, usually they have a post-ictal state. So a post-ictal state means that they actually either have some amnesia, they have some confusion, and guess what else they could have if there is impairment? Todd's paralysis. Okay? So important to remember that. So if you have a focal seizure that is with impairment, it means it's involving the reticular formation, the thalamus, there's a loss of consciousness. They also can have auras, automatisms, déjà vu, all of that stuff, and they have a post-ictal state with confusion, amnesia, lethargy, as well as potential Todd's paralysis. If there is a focal seizure without impairment, there is no thalamic involvement and there is no reticular formation involvement. So there's no impairment with respect to loss of consciousness. So it's just a focal seizure that's firing and involving one half of the cerebral hemisphere without involving the thalamus and the reticular formation. So there should be no loss of consciousness. There's usually no auras, and there's usually no post-ictal state. Okay, that's the big things to remember for that. The last thing that I want to talk about before we go on to generalized seizures is that there's something interesting, and it's a nice prelude into generalized seizures, is focal seizures with impairment can lead to generalized seizures, because we said it can secondarily generalize. How does it do that? So here's what's really interesting. let's say here you have a focus of epileptogenic kind of potential. It's firing, leading to that abnormal electrical activity that's spreading throughout that hemisphere. Even comes down and involves the thalamus and involves the reticular formation. So now you get impairment. But then enough electrical activity can pass from one cerebral hemisphere over into this cerebral hemisphere. And now you get this abnormal electrical activity that is in both cerebral hemispheres because it passed through the corpus callosum. So the corpus callosum is a commissural fiber connecting both cerebral hemispheres. So if these focal seizures are powerful enough that they cause impairment, spread through the corpus callosum enough to involve the other cerebral hemisphere, now you have bilateral hemispheric involvement. What is bilateral hemispheric involvement that is also involving the thalamus and the reticular formation called? A generalized seizure. So this was a focal seizure that became generalized. So this is very, very important. What you really want to remember with these is that usually this presents as a type of seizure that we're going to talk about within the generalized topic called a tonic-clonic seizure. Now, how do I know if a person had a generalized seizure or they had a focal seizure with impairment and it became generalized? Usually, if there was a history afterwards, or you could find there in some way, they had a history of aura, they had automatisms, they had some type of focal seizure symptoms. So in other words, maybe they had some unilateral shaking, their eyes deviating, their head turned to one side, and then on top of that postictal, they have Todd's paralysis. That may clue you in that this was never really a generalized seizure from the get-go. It was a focal seizure that secondarily generalized. Ninja nerds, we went through focal seizures, talking about the different types, the with impairment, without impairment, and then on top of that, secondary generalization. Now let's move into the beast, generalized seizures. Now, generalized seizures usually, again, involve bilateral hemispheric involvement. So bilateral hemispheric involvement that involve the thalamus and involve the reticular formation. So there is definite loss of consciousness, and there is definitely a post-ictal state. But it's a post-ictal state in the motor type of generalized seizures, because there's actually two types, and we'll talk about these. The obvious one is the generalized motor, and then the second type is the non-motor, which we also call absence seizures. Okay? But big overall theme here, generalized seizures, bilateral hemispheric involvement with impairment because of involvement of the thalamus and the reticular formation, has a post-ictal phase, especially in the generalized motor, but there is two types, motor, non-motor. Let's talk about the generalized motor. How can a generalized motor seizure present? They can present like we talked just above. They can present as a generalized atonic, a generalized clonic, a generalized tonic, a generalized myoclonic, all with impairment and all bilateral, or the classic type, the tonic-clonic, a mixture of tonic and clonic. We also give this the name grand mal seizure. This is the classic convulsive type stiffening as well as jerking movement of bilateral aspects of the body, trunk, everything. Whenever there is this tonic-clonic seizure because of generalized bilateral hemispheric involvement, it leads to insane muscle contractions of various parts of the body. Not only do you see it of the limbs, so upper limbs, lower limbs, trunk, but guess what else you see? The exams love to ask you this. It also involves the muscles of the respiratory system, and those suckers contract so hard they let out a big burst of air. And so when it hits the respiratory system, it can lead to a kind of a cry or like an involuntary scream. Okay? If it involves the extraocular muscles, it loves to pull those eyeballs up and lead to an up gaze or an up rolling of the eyes. If it involves the oropharyngeal muscles, it loves to clench down on those so hard so that all your oral secretions pool up in the oral cavity. So it causes pooling of oral secretions. That's why sometimes in the movies and things like that, they like to show you like, oh, they're foaming out of the mouth. It's probably seizures. That's kind of the view of that. The other thing is it causes intense contraction of the mastication muscles, your chewing muscles. What does that do? You clench down. Unfortunately, what could come between that teeth? The tongue. And so that whenever these contract, this can cause tongue biting. Oh man, it's making sense, isn't it, baby? All right, what else we got? It also can involve those good old sphincter muscles. So if it causes the release of the sphincter muscle around the urethra, the release of the sphincter muscle around the anal sphincter area, what can this lead to? It can lead to poo-poo pee-pee. It can lead to incontinence. So they can have urinary incontinence or fecal incontinence. What else? There's also autonomic involvement. So a generalized motor seizure, we're seeing a lot of the kind of somatic type of involvement here, but you also get the autonomic involvement. Okay, and this can even exacerbate the incontinence as well, but it can also increase the activity of your heart. So it can increase the beating activity or the action potentials throughout the heart, leading to an increased heart rate, or increasing the contractility of the heart, leading to an increase in blood pressure. So it can also lead to hypertension and tachycardia. So again, generalized motor, like particularly tonic-clonic of that type, grand mal seizures lead to loss of the consciousness. They lead to tonic-clonic movement of the upper extremities, lower extremities, trunk, head, neck, as well as involuntary scream, cry, up gaze, pooling of oral secretions, tongue biting, incontinence, and tachycardia and hypertension. And then afterwards, they have a postictal state where they have amnesia, confusion, lethargy, and that can last for a decent amount of time until they return back to their baseline. Okay? The last type of seizure here that I want you guys to remember that are part of the generalized type are called generalized non-motor seizures. And these are classified as what's called absence seizures. So absence seizures. Now absence seizures are also kind of defined as petit mal. So petit mal seizures. Now, absence seizures are very interesting. What can happen with absence seizures is they can have everything can kind of black out on them, and they can kind of look like they're staring out or daydreaming, as we can kind of say it here. So there's kind of like staring out into the abyss, or they're daydreaming. Then that can occur. So again, absence seizures do what? They can cause this staring out. They can cause this daydreaming effect. All right, engineers, what the heck happened? You guys just had an absence seizure. Everything kind of blacked out for you, and then you guys came back, and this is what happened. So where did we leave off here? We talked about absence seizures leading to staring out, daydreaming, but here's what's really interesting. It's non-motor. Usually, there is no loss of muscle tone. So they don't actually collapse in any way, shape, or form. They just sit there and stare out like they're daydreaming. Sometimes it can actually be misdiagnosed as ADHD, very interestingly. Sometimes in the atypical types of generalized non-motor absence seizures, this can present with automatisms. So again, sometimes they may stare out, daydream, no loss of muscle or postural tone, but they have that rapid blinking of the eyes, they have the lip smacking and chewing. Sad thing with these is they can happen up to 100 times a day. What's interesting about this is that there is no post-ictal state for this. Okay? One other thing that I want you guys to remember, we'll talk about it with diagnostics, but I want to briefly talk about it. Absence seizures are a very classic thing here, and what happens with these is that whenever people get EEGs, whenever you obtain an EEG of these patients, and we'll talk about it with diagnostics, that's why you get EEGs and electroencephalograms, this shows a very classic pattern that you guys need to remember for your exams, and it presents as a 3 Hz spike and wave pattern. So I just wanted to kind of make sure that we preface this within the diagnosis. On the EEG with absence seizures, you can use EEG to see this classic 3 Hz spike and wave pattern as well. Okay, so that kind of finishes up our clinical features discussion. Now let's start going into the diagnostics. All right, Ninjas, we're at the diagnosis. The person came in, they were seizing based upon the features that we talked about, whether it was a focal or generalized seizure. We got to figure out, why did they seize? So what if the person comes in and upon chart review or per the patient or per the family, this person has a history of seizures? Well, maybe this isn't kind of a seizure from an underlying thing that we have to evaluate here. Maybe they just truly have epilepsy. So if they have a history of seizures, how do we define epilepsy? So it's 2 or more unprovoked seizures greater than 24 hours apart, or a unprovoked seizure with a 60% recurrence rate according to the Epilepsy Foundation definition. So if they fit that definition and they have epilepsy, what do you do about going to elucidate the problem here? The next thing you do is, if they have epilepsy, it's most likely that they're on an anti-epileptic medication. So we need to assess the adequacy of that anti-epileptic. So what do we need to do? We need to assess adequacy of the anti-epileptic that they are taking. How do we do that? Check a level. If they're on a particular drug that you can check a level for, check the AED level. If you check the AED level and it is low, they have a low AED level. So let's say that, for example, they're on phenytoin. You get an AED level of the phenytoin, you get a phenytoin level, and it's subtherapeutic. What do? You increase the dose to get it into the therapeutic range. So increase the dose, and maybe that was the reason that they seized it. They just weren't actually within the appropriate therapeutic range of their AED. What if you take an AED level and you have a normal AED level? Okay. Well, then guess what you can do? If you have a normal AED level, so let's say they check the phenytoin level, it's in the normal range, but you still have some wiggle room. You can get up to the maximum point of the dose before it becomes supratherapeutic. What can I do if I have some wiggle room then? Increase the dose if you have some wiggle room. If you're at a normal AED level and maybe you're close to the maximum dose and there's no point of increasing the dose of that AED, what would you do? Switch the anti-epileptic drug. So switch to another anti-epileptic drug. Okay? That is the important thing to remember. The next thing that you guys need to remember here is, what else could we be thinking about here? If we have a patient who has a normal AED level, we switch them to another anti-epileptic drug, another thing to be thinking about is there an underlying cause? C, other algorithm. And that's what we're going to go into the next part. Okay? So, to briefly recap this part, patient comes in with a seizure, has a history of a seizure, you suspect epilepsy. You want to assess the adequacy of the anti-epileptic if they're on that one. If they're on it, check a level. If it's low, increase the dose. If it's normal, but you still have wiggle room to keep it to the max therapeutic range, increase the dose. If it's in the normal range, but you don't have a lot of wiggle room, switch it to another anti-epileptic drug and consider an underlying cause from the other algorithm. Okay? Now, the next thing here is they have a first time seizure. So there's no history of seizures. This is the first time that they've ever seized. You have no history of it on chart review from the patient, from the family, whatever. You need to go through these causes and figure out which one of these is the reason that this person seized. First one is vascular. What were the causes of vascular? Acute ischemic stroke, subarachnoid hemorrhage, intracerebral hemorrhage, anoxic brain injury, and PRES, posterior reversal encephalopathy syndrome. What could I do? I could get a CT. I could get an MRI, and if I really wanted to, especially for subarachnoid hemorrhage, what else could I do? I could get a lumbar puncture for subarachnoid hemorrhage, right? Good enough. Okay? Infectious etiology, what were the causes? Meningitis, encephalitis, brain abscess, what do? get a CT, get an MRI, get a lumbar puncture, okay? So CT, MRI, maybe get a lumbar puncture. You could also obtain blood cultures. You could also obtain a CBC. Why a CBC? Maybe they have an elevated white count. That clues you in. There's an infection. Blood cultures. See if there was an infection that was in the blood and that spread to the brain, or if they have sepsis. Lumbar puncture, because maybe there'll be infectious pathogens within that cerebrospinal fluid if they have meningitis or encephalitis. So on top of a CT and MRI to help to see if there was any brain abscess, you can further evaluate that. How do we further evaluate it? I can actually go the next step, which is doing what's called a stereotactic aspiration, where you actually go in and suck some of the fluid or kind of biopsy some of that fluid or abscess out to see what kind of pathogens are there. So you know what types of antibiotics, antifungals, antiparasitics, whatever it needs to be to treat that patient, okay? So we got so far vascular infectious. What about trauma? Well, if they come in with a history of trauma and you obtain a CT scan that shows either a epidural hematoma or a subdural hematoma, I'd say that you're pretty darn good there, okay? What else? Autoimmune. Now, autoimmune's a little bit different. If someone has autoimmune encephalitis, this is usually a little bit lower. What if they have a history of lupus or systemic lupus erythematosus or some other autoimmune disease? You can further evaluate that with an autoimmune panel. And so sometimes an autoimmune panel starts off with just kind of like an ANA, so an anti-nuclear antibody with reflex. And that will just send off a bunch of other antibodies that may be related to different types of autoimmune disorders. The other thing is, what if you suspect a paraneoplastic type of syndrome? So maybe there is a cancer somewhere, and that cancer is what's actually leading to antibodies being produced. Well, how do I find the cancer? Maybe I need to do a full CT scan. So maybe I need to obtain a CT scan of the chest, abdomen, and pelvis. Also, when you get into these autoimmune kind of like panels, you can also check very specific antibodies that are present with kind of autoimmune encephalitis, like anti-NMDA, anti-WHO, anti-GABA, anti-AMPA antibodies. There's so many different types, but that can be included within that panel. All right, so we got our autoimmune types, okay? Metabolic. What do I do here? Well, think about it. What was the first one we said? Thymine. So check a B1 level. That could be low. They have hypoglycemia or hyperglycemia. Check a point of care, glucose. They have some type of electrolyte abnormality like sodium, calcium, magnesium, phosphorus. I can get a BMP and add on magnesium and phosphate levels, because a BMP is going to give me what? It's going to give me their sodium, it's going to give me their calcium as well, okay? And it can even give me a glucose. What else is good about the BMP? It'll give us their renal function. So if there's any elevation in urea, elevation in creatinine, which is a cause for uremic encephalopathy. If I want to, let's actually take this a step further. We could, you know what a BMP, you can add a BMP plus LFTs. When you had a BMP plus LFTs, what is that actually called? It's a CMP. So if I really wanted to save money instead of ordering 2 tests, what I really could do is I could get a CMP adding on magnesium and adding on phosphate. Why? A BMP will tell me the sodium, it will tell me the calcium, I'll get the mag and phos separately, and then the CMP also gives me their LFTs. So it'll tell me if there's an increase in AST, ALT, ALK phos, maybe telling me that there's a liver problem. Also, it'll tell me their renal function, their BUN and creatinine, telling me if there's a renal function there as well. So it'll help me with hepatic encephalopathy, uremic encephalopathy, or any other electrolyte derangements. What was the other molecule that I told you though to add on, because it could be the trigger for the seizure? Besides the LFTs for the liver, what else could I add on? An ammonia level, okay? Look to see if there's an elevation in their ammonia. One more cause for the metabolic that I want you guys to remember is Thyroid, hyperthyroid. So get a thyroid function test. And the way that we check this preferably is TSH with a reflex. So if the TSH comes back low, they'll send in to check for a T3 and T4 to see if that is high, okay? Alrighty, so these are the big things to think about here. The next one that I want you guys to think about as a potential cause and how we're going to evaluate that is idiopathic. C, epilepsy. We already talked about that. You're assessing the anti-epileptic drug level and adequacy. And why is that important? These anti-epileptics, they're not always perfect. They come with side effects, which we'll discuss in a separate video on anti-seizure medications. And so sometimes people can be on an anti-epileptic and just stop taking it because of the side effects, or because they're taking it and it's just not at that therapeutic level, or it's just not the right epileptic for them and they need to try another one. What's the next one to evaluate? Neoplasia. So they have a glioblastoma, they have a meningioma, they have a metastatic type of cause from a malignancy. How do I figure that out? A CT can start off with that, maybe find some type of abnormal mass, and then I want to get an MRI with contrast. Okay, that's another big thing to think about. When we talked about abscesses, we said MRI. MRI with contrast, you should add that on for abscesses because it enhances the rim, showing that ring enhancing lesion when you add contrast. You want contrast for cancers as well because it'll enhance that mass. Okay, so MRI with contrast, a CT scan to start, which may lead to an MRI with contrast to follow up, and then sometimes to figure out the true etiology of it, you may even need to do kind of a resection or biopsy to figure out what the actual pathology of that mass is, what the cause is, if you really are interested. The other thing is when we say CT, there's actually two of them. You get the CT of the head, and also if you suspect a malignancy, like a metastatic cause, get a CT chest, abdomen, pelvis. Okay? Drugs. So drugs, there's so many different types of drugs that we got to think about. So go through and evaluate their med list. So you really need to look at their medication list. What are they taking? And figure out, is it one of those Otis Campbell things that we talked about? If it is, then what do I need to do? Discontinue that medication. But the other thing is, what if it was something else? Like it was ethanol, it was cocaine, it was like amphetamine, it was a benzo, it was an opioid, something like that that I may be able to pick up on a toxicology screen. So what I may do is a toxicology screen. Okay? And usually that's a urinary drug screen is what we'll kind of start off with. Okay, now remember we added into the list there demyelination and degenerative diseases. You can also do imaging for that as well. The next part is eclampsia and everything else. Eclampsia, what did we say was the primary things? You needed high blood pressure, seizures, and you gotta be pregnant. So what am I gonna order? I'm gonna order a urine and also maybe even a serum beta HCG. Okay, to see if it's elevated because maybe they're pregnant and that's the reason why this person is seizing. Okay, the other thing is, are they febrile? So check a temperature. So if they have a fever, that could be a potential cause. And then genetics, that may require more kind of in-depth tests. So you may have to do more genetic testing. Okay, and we're not going to go down that rabbit hole. The only other thing that I want you guys to add on to this is some additional labs to think about whenever you're trying to work up a patient with who's seizing. Other things to add on, because it can help if you're trying to really determine if the patient's seized, is you can add on a CK level, so a creatinine kinase level, a CK level. Sometimes in these patients who have pretty bad seizures, this will be increased. And the reason why is you're causing those muscles to contract and contract and contract, and they end up rupturing and spilling out some of that creatine kinase into the blood. The other thing is, whenever your muscles are just constantly burning through that like actual oxygen and consuming and consuming and consuming so much oxygen to break down glucose, make ATP so that your muscles can keep contracting when they're in this seizure state, is it can increase the lactate. And it can lead to an acidosis. What type of acidosis? A lactic acidosis, type B lactic acidosis. And so sometimes you may even add on maybe an ABG to help with that process. But getting a lactate level, getting a CK can also be important. Another thing to add on is prolactin. You're probably like, what the heck? I'm not spilling milk out. What the heck? Well, what does this have to do with anything? Sometimes prolactin levels, if they're elevated and a patient comes in with seizures, but you're not sure, is this a real seizure or is this a pseudo seizure, a psychogenic non-epileptic seizure? Prolactin levels, if they're elevated, they more suggest seizure versus so the psychogenic non-epileptic seizures, also called pseudo seizures. The other thing that you can check is a troponin. Troponins, usually whenever muscles are damaged, muscles contain troponin. So also you can have troponin leaks. And again, this could be indicative of skeletal muscles rupturing open and releasing that troponin because they're seizing and you're trying to cause your muscles to go into this rhabdo type of state. So you may be able to pick up rhabdomyolysis by an increase of CK, a lactic acidosis by an increase in lactate, and an ABG suggesting metabolic acidosis, elevated prolactin more suggestive of seizure versus a pseudo seizure, and then troponins, you can add that one on as well to look to see if there is a troponin leak. Okay? And if you get troponins, you should add on an EKG just to make sure that you rule out any arrhythmias as well. Because you know what another type of differential for seizures is? Syncope. And so sometimes syncope can also present what looks like it is actually a seizure, but it's actually an underlying arrhythmia, a cardiogenic cause that caused them to pass out and look like an actual seizure. So add on an EKG. So we talked about the additional labs, but there's one more thing that we need to add on that definitely aids in the diagnosis of seizures. Now, just because it's not present on this type of test does not mean that the person doesn't have seizures. We just might not have picked up on it. But another test that definitely needs to be done to kind of evaluate if there's seizures present is you need an EEG, an electroencephalogram, determining the electrical activity within different parts of the brains to seeing if there's any weird epileptic activity that is occurring there. So very, very important. Another test that you need to add on is an EEG, looking for abnormal electrical activity within the central nervous system. All right, now let's talk about treatment. All right, engineers, now we need to talk about the treatment of seizures or epilepsy. So go back. A person seized, okay? When they seized, you need to treat them with anti-epileptics depending upon if they've been seizing for a long period of time. We'll talk about what status epilepticus. You can treat them with anti-epileptic medications. While you try to stabilize them with these anti-epileptic medications, you should be searching for an underlying cause. As you search for them, that underlying cause based upon the diagnostics we talked about, if it's a reversible cause that's causing the seizure, you treat that underlying cause, and then maybe you can discontinue the antiepileptic. If it is a cause that is not easily reversible, you may have to continue the antiepileptic until that cause has resolved. But it's important to remember that seizure is a symptom of an underlying disorder that we talked about with the vitamin D and E causes. If you can reverse it, it could potentially stop the seizure. If you can't, and they have epilepsy or a non-reversible cause, you may need to keep them on an anti-epileptic, okay? What are these anti-epileptics? Before we talk about all these dang anti-epileptics, we need to have a basic remembrance and understanding of that pathophys for seizures, right? What was the basic concept behind seizures? There was two things. There was an increase, there was a decrease in the inhibitory GABA pathway, right? So a decrease in the inhibitory GABA pathway. That was one cause. The other one is there's an increase in the glutamate or stimulatory pathway. So it's two causes here that are really kind of hidden here, glutamate or stimulatory pathway. So increase in the glutamate or stimulatory pathway, or a decrease in the GABA inhibitory pathway. Either of these two things, or compounded on one another, leads to increased depolarization of these postsynaptic neurons, increased action potentials, increased abnormal, excessive, synchronous electrical activity, seizures. So what do we need to do? We need to give drugs that either shut down the stimulatory glutamate pathway, or give drugs that are going to stimulate the inhibitory GABA pathway. So let's briefly talk about some of the pathways here with the glutamate. First thing is, let's say here's a glutamatergic neuron. If action potentials are moving down this glutamatergic neuron, it'll open up voltage-gated sodium channels that are present on the axon. When these voltage-gated sodium channels are open, sodium will rush into the cell, cause the inside of the cell to become positive, and then again depolarize the next segment. So really, these voltage-gated sodium channels on the glutamatergic neurons are very, very important, because what do? They allow for depolarization of that glutamatergic neuron. Very, very important. Voltage-gated sodium channels on the actual glutamatergic neurons are important because they allow for depolarization of this neuron. If this neuron depolarizes and triggers action potentials that move down this axon to the synaptic bulb, guess what it'll do? It'll lead to the release of neurotransmitters from this neuron, like glutamate. And glutamate will then act on this postsynaptic neuron, stimulating it and triggering action potentials. So what if I give drugs that inhibit or block these voltage-gated sodium channels? If I block these sodium channels, can positive ions come into the cell? No. So I am decreasing or inhibiting these positive charges from coming in. If I decrease positive charges from coming in, am I going to be able to trigger action potentials? No, I'll decrease action potentials. If I decrease action potentials, am I going to be able to release glutamate from these neurons? No, decreased glutamate leads to decreased action potentials being carried down this axon, less seizures, right? So the good thing to ask ourselves is, what are the name of these drugs that block the sodium channels? You can remember them by very problematic to let phosphonatoin cuddle. So V is valproate. So valproate or valproic acid. P is phosphonatoin. T is topiramate. L is lamotrigine. F is phosphonatoin. And C is carbamazepine. Carbamazepine, okay? So, basic concept there, sodium channel blockers inhibit the sodium channels on the glutamatergic neurons, decreases action potentials down those glutamatergic neurons, decreases glutamate release. If there's less glutamate, what happens? That means less glutamate binds onto the NMDA receptors and AMPA receptors. That means less cations enter into the cell. Less cations decreases depolarization. And if you decrease the depolarization, you decrease action potentials, decreasing seizures. Boom, bada bang. All right, what else? All right, well, the other thing that you want to add on here is that we didn't explain how these action potentials lead to glutamate release. Let's explain. These action potentials, right, that are propagating down the axon, this flow of positive charge, can also activate these specialized channels only located on the axon terminal, called voltage-gated calcium channels. If these positive charges stimulate these voltage-gated calcium channels, guess who starts flowing on in? Calcium. Guess what calcium does? Calcium binds onto special types of receptors called SV2A receptors that are present on these vesicles, binds onto them, and engages this synaptic protein with the cell membrane to induce glutamate release. Glutamate acts on AMPA and NMDA receptors, causes cation influx, causes depolarization, causes action potentials. If I give a drug like a calcium channel blocker, which will inhibit calcium entry, calcium can't enter, decreased calcium enters, decreased binding to the SV2A receptor, decreased fusion to the cell membrane, decreased glutamate release, decreased activation of NMDA, AMPA, decreased cation influx, decreased depolarization, and decreased action potentials. You guys get the point. What are the drugs to remember for this class? This one, I want you to remember what's called gabapentin, which is kind of an old school one, and one more called ethosuximide. Ethosuximide, I want you to remember a very specific type of seizure we treat this one with, and this is absence seizures. So absence seizures respond best to what kind of drug? Calcium channel blocker, which type? Ethosuximide, very important, very high yield. Okay, we got the sodium channel blockers, calcium channel blockers. We got another one, these SV2A blockers. So this is a drug, we already kind of a little bit discussed it, this is where calcium will bind on, right? So calcium will bind on to this actual SV2A receptor. When calcium binds onto the SV2A receptor, what will happen? This membrane, this vesicle will fuse with the membrane, induce glutamate release. What if I give a drug that blocks calcium from binding to the SV2A receptor, or binds the blocking of that synaptic protein to fuse with the cell membrane? Either way, whether it's not interacting with calcium or not fusing with the cell membrane, what's the end result? Think about it. Less of this SV2A binding with calcium or fusing with the cell membrane results in decreased glutamate release, because you're having less fusion with the cell membrane. Less NMDA, AMPA activity, less cation influx, less depolarization, less action potentials. What is the name of the drug that inhibits this SV2A protein? Levetiracetam. An easier way to remember this one is by the brand name Keppra. Okay, that's why it's easier to remember that one. But either way, SV2A blockers like levetiracetam inhibits the binding of calcium to the SV2A, or inhibits the fusion to the synaptic membrane, decreasing glutamate, decreasing action potentials, decreasing seizures. Okay? There's one more drug that I want to add on to inhibiting this glutamate pathway. What is that? There's actually drugs that can target the NMDA receptors. And this one's a very interesting one. And this is called ketamine. Ketamine is a very interesting drug. And what it has the ability to do here is block glutamate from binding to the NMDA receptors. If you block glutamate from binding to the NMDA receptors, what happens? There's less positive charges coming into the cell, like cations. Less cations, less depolarization, less action potentials. So to summarize the decreasing the stimulatory pathway, what do we have? Sodium channel blockers, calcium channel blockers, SV2A blockers, and NMDA receptor blockers. So we blocked that part of the seizures. We can also affect this part, which is increasing the inhibitory pathway, the GABA pathway. What drugs can we use here? Well, let's remember what the GABA pathway is involved in. First thing you need to remember is GABA is actually formed from a molecule called glutamate. So glutamate is actually converted into GABA, and then it's incorporated into these vesicles. And then what happens is when these actual vesicles fuse with the cell membrane and they release GABA, GABA will bind onto these little pockets here of these very special receptors. And these receptors are called GABA A receptors. When it binds onto the GABA A receptors, the channels open and allow for anions like chloride to enter into the cell, making the cell extra negative. It becomes super, super negative, and this causes hyperpolarization. hyperpolarization. Now, hyperpolarization is where you make the cell extra negative, like we did. The problem with that is that hyperpolarization affects your action potentials and decreases your action potentials. But you're like, wait, if I'm decreasing the action potentials, then I'm not having seizures, right? Well, remember, what was the problem with seizures? The problem with someone having a seizure is that these GABA A receptors were in some way, shape, or form either dysfunctional or not responsive as well as they should be. And so because of that, there was actually kind of decreased chloride ions coming in. There was actually decreased hyperpolarization, and if your cell's not as negative, what does that mean by that process? It's actually positive. And if that's the case, you can actually depolarize these cells and lead to increased action potentials, okay? So I need to give drugs in some way, shape, or form to try to increase this GABA pathway or overcome these dysfunctional GABA A receptors in some possible process. So what we can do here is, another thing that you want to remember, a part of this pathway, we got to add on, it's not over, right? Once GABA's done exerting its effect on these GABA A receptors, it shouldn't sit in the synapses. It should get brought back up into these channels here, brought back into the terminal bulbs. Once the GABA is brought back into the terminal bulbs, it can get converted into a molecule called succinic semialdehyde. You're probably like, what the heck, why do I need to know this? Well, there's an enzyme that helps to mediate this process, and basically it kind of renders GABA ineffective in being formed at that process there. So this protein, and we're going to draw this in blue here, we'll kind of have this like little dude here. Look at this guy. Look at this cute little dude. Got a little nose, got a little eye, got some hair, some leggies, and then he's got his arms involved into this reaction. What is this enzyme here called? GABA transaminase. Okay, we'll put transaminase, okay? So this is your GABA transaminase, which is converting GABA into what's called succinic semialdehyde. And that basically renders GABA ineffective from being able to be recycled, okay? So that's our basic pathway. GABA is released, acts on GABA A receptors, causes anion influx, hyperpolarizes, decreases action potentials. But in seizures, you actually have dysfunctional GABA A receptors. They don't respond to the GABA as well. They don't allow for anions to come in. They don't hyperpolarize. Instead, they depolarize and cause increased action potentials. Also, GABA gets reuptaken back into the neurons via the GABA reuptake proteins and then converted into an inactive molecule called succinic semialdehyde via the GABA transaminase. Now, we have drugs that can target this pathway to increase the GABA pathway. Let's talk about them. The first thing is, where was the first part of the path when we released GABA? The GABA A receptors, right? So the GABA A receptors, can we use drugs to make these GABA A receptors either more sensitive, or we just stimulate the living crap out of it enough that we cause anions to rush in? Yeah, we can give drugs that are agonists to GABA. What are those drugs? Benzodiazepines. So this is a big one to remember. Okay? So what are some of these benzodiazepines? I'm not going to list them all because there's so many. We'll have to have a separate lecture on just those. But I want you to remember lorazepam as a very, very important one. Diazepam is another important one. And finally, midazolam. These are very important drugs, okay? The next one I want you to remember is propofol. So propofol. Another one is phenobarbital. And there's also other ones in there as well, but these are the real big ones that I want you guys to remember, okay? So, GABA A agonists, how will they work is the good question here. What will they do? The GABA A agonists will come and stimulate these GABA A receptors. If you stimulate the GABA A receptors, what do? You increase the chloride ions. If you increase the chloride ions, you increase the hyperpolarization because you make the cell super negative. If you make the cell super negative, it's unlikely that it'll depolarize. Instead, it'll have decreased action potentials and decrease your seizures. Okay? All right, that's that one. Now, what else? The other part of the pathway here is GABA gets reuptaken back into these neurons. What if I keep GABA in the synapses and I actually prevent it from getting reuptaken into these actual synaptic bulbs? Son of a gun. If I do that and I inhibit this uptake, then GABA will stay in the synapses longer. If it stays in the synapses longer, it'll stimulate these GABA receptors more, increase chloride ions, increase hyperpolarization, and decrease the action potentials. What is the name of the drug that can do that? Tiagabine. The next thing, not only can I actually prevent GABA from getting reuptaken, but what if I try to prevent GABA from being converted into this inactive form and instead try to inhibit this process and allow GABA to be recycled, put back into the vesicles, and excreted again? So I inhibit this enzyme from doing this activity. What is the name of those drugs that are GABA transaminase inhibitors? You like how I did that? Inhibitors. These are vigabatrin and valproate. And that would cover our seizure medications, our anti-epileptics, if you will. Son of a gun, right? Okay, we've stabilized these patients by doing what? Reversing their underlying cause, if it was reversible. Putting them on anti-epileptics. And if they still had a cause that we couldn't reverse, we should keep them on these epileptics consistently. Now, there's one more scenario, an extremely emergent complication that can arise from seizures. And that complication is known as status epilepticus. Status epilepticus is when a person, it's two definitions if you will. A seizure that's lasting greater than or equal to 5 minutes. That's a long time for that brain to be on fire, baby. We don't want that. Another definition is you have a seizure followed by another seizure without a return to baseline. You have a seizure after another seizure after another seizure with no return to baseline in between. That is status epilepticus. This is a neurological emergency. What do we do? While you're going to be doing the same diagnostic workup we just talked about, figuring out the underlying causes, vitamin D and E workup, you need to stabilize these patients. How do we treat them? First and foremost, initial treatment should always, in any emergent situation, begin with what? A, B, C's. Airway, breathing, circulation. Are they protecting their airway? If not, intubate if they're hypoxic. So are they hypoxic? I think this is a good question to ask. If they are, intubate them and protect their airway. Also, again, control their hypertension, because most likely they're going to be hypertensive, and control their tachycardia. And we can do that in other ways as well. So that's our ABCs. The second thing is you need to reverse the actual causes. So easily reversible causes. Let's put easy ones. So ones that it wouldn't take a lot of investigation, things that we can quickly figure out. So what if the person comes in, you get a quick point of care glucose, and they have hypoglycemia. What do I give for hypoglycemia? I give them D50. What if they come in and they say, oh, this person has a history of alcoholism. So they have a history of alcoholism, which leads me to think vitamin B1 deficiency. I give them thiamine. I give them a thiamine infusion, or a bolus, if you will, okay? What if the person is pregnant? If they're preggo, or you get a beta HCG, but obviously if they come in with a big old bump, a baby bump, what are you going to do? Suspect eclampsia. And if it is eclampsia, it's not really going to respond great to all of these anti-epileptics. Guess what you give them? Magnesium. You give them magnesium, 4 to 6 grams of magnesium. Okay? The other one is if they come in with maybe a history of tuberculosis. and they've been on isoniazid, you need to give them something to reverse the isoniazid toxicity, and you give them vitamin B6. These are the quick things that you can do based upon the clinical vignette and in real life to reverse these seizures quickly, okay? The third thing that you'll do after you try this stuff is you'll start getting a benzodiazepine to shut down, or actually to stimulate those GABA A receptors, increasing the GABA activity, shutting down those seizures. And so that's the third thing that you'll do, is you'll get on board with your benzodiazepines. Benzodiazepines. Okay, what are the benzodiazepines that you will start? The preferable one, if you have IV access, is lorazepam, and you can give this one as kind of like a 4 milligrams IV push, okay? The other one is if you don't have IV access, you can give a drug called midazolam, okay? And sometimes they give this 10 milligrams IM. But either way, you give a benzodiazepine to increase the GABA A activity and cause to shut down those seizures, okay? So quick thing right away, ABCs. Reverse easy causes, start a benzodiazepine. Okay, you've done that. They're still seizing. What do you do next? The next thing you do is you load them up with an anti-epileptic drug. We already talked about tons and tons of anti-epileptic drugs. Which is the best one for status epilepticus when a person is coming in with a generalized tonic-clonic seizure? The best ones for generalized tonic-clonic seizures include levetiracetam, phenytoin, fosphenytoin, valproate. These are just some of them, but these are kind of one of the more common ones. Another one that we can talk about a little bit later in a future video is lacosamide as well. We'll talk about that one again later, lacosamide. I'm not going to talk about it just yet. But these are some of the drugs that you can load them up with. So, how should you be doing this? Patient comes in, you stabilize their airway, breathing, you control their circulation. You search for any reversible easy causes, reverse them. Still seizing, give them a benzodiazepine. After you give them the benzodiazepine and they're still seizing, load them up with an AED just after you give them the benzodiazepine. So again, what do? Reassess, okay? After you've done all of this to this point, if they're still seizing, you need to intubate and start preparing for some more heavy-duty IV anti-epileptic drugs, okay? So now we go to the next part. So what have we done? ABCs, reverse easy causes, give them a benzodiazepine, load them up with an anti-epileptic. If they're still seizing, we're going to intubate them. And if after we've done that, so let's kind of just continue this process, they're still seizing, we've intubated, and now we're going to start IV anti-epileptic drugs. These are the heavy-duty bad boys. Okay, so we've loaded the anti-epileptic, as we've discussed with these. The next thing that we're going to do, IV anti-epileptics. These include a couple. The first one is going to be propofol. So propofol is going to be a very important one. This one is going to try to shut down that GABA A activity. The next one that you could give is IV midazolam. Okay, so midazolam. Another option includes ketamine. So these are three of the big ones here. And then one more option that you have if you really need it is what's called pentobarbital, which will also help to shut down those increase the GABA A activity and shut down those seizures. So these are some of the hardcore IV infusions that you can give to shut down the seizures. The other thing that you should do in the interim is you should also add on the maintenance doses of the selected anti-epileptic drugs. So for example, if you started them on levetiracetam, you load them up with 60 mg per kg, After you've loaded them up, then you give them a maintenance dose. Maybe you give them 1,000 milligrams BID. On top of giving them propofol or midazolam or ketamine or pentobarbital. Okay? If these still haven't worked, then sometimes you may even start exploring other options, such as like the ketogenic diet and other kind of like downstream options as well. Okay? And so once you get into this part, if you still have the person seizing, again, search for underlying cause. And if that is the case, if you still have them seizing after putting them on maybe propofol, midazolam, ketamine, pentobarbital, you also have maintenance doses of anti-epileptic drugs, and you've tried the ketogenic diet, still not working, search for other underlying causes, because there must be something that's hidden there and you just have to treat that, and that will ablate the seizures. Sometimes what may even happen is you add things. Sometimes you may put something on, maybe you might have propofol and Versed or midazolam. Maybe you'll have propofol and ketamine. And maybe you'll have propofol and ketamine and have another maintenance dose of some anti-epileptic. Or maybe you're adding multiple anti-epileptic medications. The point is, what is the step-by-step? Very important to remember. Ready? ABCs. Reverse the easy causes, benzodiazepines. After they've done that, still seizing, load them up with an anti-epileptic, one of these. If they're still seizing after that, and you reassess them and they're still seizing, intubate. After you've intubated them, put them on IV anti-epileptics like propofol, midazolam, ketamine, pentobarbital, or a combination of those two, and then give them maintenance doses of their anti-epileptics that you've picked. If they're still seizing, you can try a ketogenic diet, but you should really figure out why they're still seizing from an underlying cause. If you reverse that, you may stop the seizures. Ninja Nerds, we've covered seizures, epilepsy, and status epilepticus.